Hi. We have good news. If you missed any of the first 3 days, or if you're interested in revisiting them, they're up now. The recordings are up on our website, which is wiparkinson.org. So go there and check them out, and check out the other great resources there. As we've been doing, I know a lot of you in the audience are new to Wisconsin Parkinson Association, so I want to just take a couple minutes to share a little bit about who we are. And in a nutshell, our hope is to be partners with you, with your health care team, to make sure that you're living as healthy and as fully as possible, and doing that today. That's our focus today. Our mission is to provide hope, community, support, and resources for people with Parkinson's and their loved ones. And as I did yesterday, I want to take one of the words from our mission statement there and just talk a little bit about how we make that real here at WPA. Yesterday, I talked about hope. Today, I want to focus on community. And one of your questions might be, why is WPA focusing on community? What's important about that for somebody with Parkinson's? And with Parkinson's, just like with any chronic disease, it can lead to isolation. And to be blunt, isolation is bad for all of us. And it's not just me who believes that. There's research behind that. There's research that shows that isolation may worsen Parkinson's symptoms. There was a recent study. It covered 5 years of data and reported about Parkinson's patients who were feeling the loneliest, the most isolated. Those people tended to get less exercise, ate less healthy, and not surprisingly, had a lower quality of life. And that's what we want to help you fight against. So here's a couple of the ways that we do that. We want to make sure that the 200 Parkinson's support and exercise groups that are all around the state of Wisconsin, we want to make sure those programs are strong. Because if you're part of one of those groups, or you've ever been part of a small group, you know how powerful they can be in building really meaningful relationships, often relationships that you're going to carry throughout your life. And WPA has dedicated a full-time staff, that's Lori Couillard, our Director of Group Engagement, whose primary job it is to ensure that these groups are active and that they have the resources to assist you. In fact, over the last 2 years, WPA has dedicated more than $100,000 and lots of mileage on Lori's car to those groups to make sure that they are active and helpful for them and the people who participate in those groups. Also recently, we've hosted 3 fly fishing programs. We've had 4 game nights and 15 social events for working professionals with Parkinson's and others. During COVID, our staff did 500 check-in phone calls just to make sure that members of the Parkinson's community were doing okay and had the resources that they need. Isolation is bad, community is good. We want to make sure finding that community is as easy as possible for you. So if you want to learn about any of those support or exercise groups or the events and programs that we have going on, please visit our website, which is wiparkinson.org. And as we get ready to get started, I'd like to thank our sponsors who helped make this webinar series possible: Medtronic, Amneal, Boston Scientific, and Kyowa Kirin. Just a note, you're muted. We can't hear you or see you, but we really want you to participate. And if you have questions for the speaker today, you can use the Q&A function, which you'll find at the bottom of your screen. Just type it in and submit it. Try to do that as early as possible. We're going to hope to get to as many of those questions at the end of the presentation. If we don't get to all of them, then we're going to do our best to address them in future publications or future programs. Today, we're going to hear from Dr. Nichelle Rothong from Aurora Neuroscience Innovations Institute in Milwaukee. Dr. Rothong is a licensed psychologist who specializes in neuropsychological evaluation. She uses evidence-based, holistic therapeutic approach that is individually centered. Today, she's going to address cognitive changes that can accompany a Parkinson's diagnosis. Welcome, Dr. Rothong.
Okay, hi, thank you so much. I'm so excited to be here with everyone. Let me share my screen. All right, hopefully everybody can see my screen now. Again, I'm Dr. Rothong, and I am a neuropsychologist at Aurora St. Luke's Medical Center in Wisconsin. And today we're going to be talking about cognitive and psychological changes that we can see in Parkinson's disease. I'd just like to mention that I don't have any conflicts of interest to disclose today. Today we're going to be discussing a little bit of background information on Parkinson's disease to start with. Then we're going to transition into speaking about the cognitive and the psychological and behavioral changes that we can see occur in the disease. So as many of you may know, Parkinson's disease is a chronic, progressive, neurodegenerative movement disorder that is characterized by 3 cardinal symptoms: a resting tremor, which is usually described as slow and pill rolling, bradykinesia, also known as slowed movement, and rigidity. A 4th hallmark symptom called postural instability used to be included, although was more recently revised out of the diagnostic criteria, but still can be seen in individuals with the condition. As we'll talk about, cognitively, we tend to see a pattern of frontal subcortical dysfunction, which I will explain what that means in a little bit. Other classic signs of Parkinson's disease may include reduced emotional expression, soft speech, micrographia, so writing that is small or starts out at a normal size and gets progressively smaller, shuffling gait when walking, and difficulty swallowing. And as we will discuss, the non-motor symptoms in Parkinson's disease have gained increasing attention and are now included in the supportive diagnostic criteria for the disorder. So prevalence and incidence. What we know is that Parkinson's disease is the 2nd most common neurodegenerative condition of adult onset following Alzheimer's disease. It affects 100 to 200 per 100,000 people. The disease affects 1% of the population over age 60. Early onset Parkinson's before age 50 is rare. And we know that the prevalence reaches about 4% in the highest age groups. Research has found that Parkinson's is about 1.5 times more common in men than it is in women. So we have gained more attention over time with looking at the non-motor symptoms of Parkinson's and how prevalent they are and how they can affect individuals' functionings. What we will be focusing on today is the cognitive difficulties, as well as the psychological and behavioral changes that we can see. So regarding the cognitive changes, we can see something called mild cognitive impairment, and also dementia. And we're going to go into these in detail in just a little bit. Psychiatric problems are also common, things like anxiety, depression, hallucinations as the disease progresses can be seen. Sleep disturbance is also very common. There's something called REM sleep behavior disturbance, which involves patients seemingly acting out their dreams. We can also see excessive daytime fatigue in Parkinson's. Pain, sensory disturbances, and autonomic dysfunction, things like postural hypotension, urinary incontinence, constipation, difficulty swallowing, can also be seen in the disease. So there are a variety of factors that can contribute to cognitive dysfunction in Parkinson's. What research has shown is that age is the greatest risk factor for developing Parkinson's disease dementia, as we will discuss in a little bit. Cognitive reserve is also something that we want to be mindful about. And this phenomena is basically our brain's ability to improvise and find alternate ways of doing things. And it's developed by a lifetime of educational, occupational, and leisure activities. And research has shown that individuals who have greater amounts of cognitive reserve can better tolerate the brain damage that is associated with Parkinson's. So that means that people who have more cognitive reserve can better tolerate more of the cognitive symptoms that can be seen in Parkinson's and still maintain their functioning. Genetics can also play a role in cognitive dysfunction in Parkinson's. Researchers have identified genes that are associated with Parkinson's, but it's important to note that only about 10% of Parkinson's disease cases are thought to be related to a genetic cause. And what that means is that most cases of Parkinson's disease are considered to be sporadic, meaning that the cause is unknown. When we look at the research that's been done, what's clear is that Lewy-based pathology, okay, is very important and thought to be the primary contribution in Parkinson's disease dementia. And what this involves is abnormal deposits of a protein in the body of nerve cells and abnormal neurites in diseased nerve cells. And these protein deposits appear to be the major cause of Parkinson's disease dementia. But as research has always pointed out, Alzheimer's disease pathology is also thought to potentially contribute to dementia in Parkinson's disease. Other conditions like vascular disease and cerebral amyloid angiopathy, hippocampal sclerosis may also play a role in dementia seen in Parkinson's disease. So let's transition to talking about the cognitive changes that we can see in Parkinson's disease. As we'll discuss, a wide variety of cognitive difficulties have been found in individuals with Parkinson's. So the most common pattern of weaknesses that we see with cognition are in the areas of attention and working memory and processing speed, visual spatial skills, memory, and executive functions. Now, I know none of us learn what these abilities are in school or in work, so I'm going to be going over them in detail very soon. Also, when I talk about cognitive changes, what I mean is different changes that we can see in thinking and memory. So cognitive is just a big umbrella term for thinking and memory skills. I'd like to just point out, as a neuropsychologist, that neuropsychological evaluation early on in the disease process is really invaluable in detecting even subtle cognitive decline and guiding interventions in Parkinson's disease. Now I'd like to discuss the various aspects of cognitive functioning and difficulties that we can see in individuals with Parkinson's disease. So the first area that I'd like to talk about is attention and working memory. So attention just means our ability to focus, and concentration is our ability to sustain that focus over time. Working memory means our ability to hold information in our mind and manipulate it. So like back in the day when we used to go out to eat at restaurants and we had to calculate a quick tip in our head, we were using our working memory skills. And what research has shown is that in patients who have Parkinson's disease dementia, we can regularly see fluctuations in attention and concentration. We can see difficulties with complex attention, which could mean that individuals have difficulty paying attention in environments with a lot of stuff going on, or a lot of distractions, or things that they need to attend to. So for example, maybe, somebody is watching TV, but then also a family member is trying to talk to them. And it's really difficult for that individual with Parkinson's to shift between a TV and that conversation successfully. Regarding the working memory impairment, how this can manifest in everyday life is that individuals may have difficulty maybe recalling an address or a phone number that was just shared with them, or recalling what was just said. Transitioning to processing speed. So processing speed is just a fancy way of saying thinking speed. So how quickly, how efficiently somebody is processing information. Processing speed is commonly impaired in individuals with Parkinson's disease. And this is thought to be related to a combination of motor slowing and something called bradyphrenia, or just slowed thinking speed. So in everyday life, what this could look like is An individual with Parkinson's disease may ask you to repeat information because they only caught a portion of what you just said, or it might take them longer to think through or process information. Next, we can look at language functioning. And although language impairment is not a core deficit that we see in individuals with Parkinson's disease, you certainly can see changes in language, okay? So let's break down what language skills actually are involved here. And we're talking really about two things: expressive language and receptive language. And expressive language is our ability to communicate via spoken or written language. And receptive language skills include our ability to understand spoken or written material. So as I just alluded to, the core language functions like our ability to read and write and our vocabulary skills are typically intact in Parkinson's. What we can see though is people have difficulties getting their words out. It's like on the tip of their tongue, but they just can't quite access it. We call this a word finding difficulty, and that's pretty commonly seen in Parkinson's. We can also see difficulties understanding complex information. So like if they have to, read a big, long document that has pretty complex language, there could be some difficulties with understanding, particularly as dementia progresses. Regarding other language changes that we can see something called hypophonia, which means that the speech of a person with Parkinson's disease becomes soft. We can also see something called dysarthria, which reflects some difficulties in enunciating. Like it could present as slurred speech, difficulties with speech articulation. So the hypophonia and dysarthria are commonly seen in Parkinson's. Moving on to visual spatial, constructional functioning, what we can see is that individuals with Parkinson's have some difficulties perceiving visual spatial material in their environments. They might have some difficulties drawing and constructing material. Now, of course, some of the difficulties with drawing might be related to tremor if tremor is present. But if tremor is not present, we can still see difficulties perceiving visual material in the environment. Where this comes up in everyday life is individuals might have difficulties judging distance. And this can be seen in a variety of areas, but it's commonly seen if people are still driving, where they're having trouble judging distance between their vehicle and the vehicle in front of them, or they're having trouble negotiating turns or parking between lines. If individuals are not driving, we can see problems with visual spatial skills impact their ability to walk. They might have trouble navigating a hallway or judging a turn, rounding the corner. They might be bumping into things. What research has found is that problems with visual spatial processing contribute to an increased risk of falls and fractures in individuals with Parkinson's disease. So that's something that we want to make sure that we're mindful of assessing early on in the disease course. So when we think about memory, there are a variety of different types of memory. Explicit memory or declarative memory is basically our conscious recollection of factual material events or previous experiences that we've accumulated throughout our life, our knowledge base. In contrast, implicit memory is also called procedural memory, and that is our unconscious recollection of how to perform activities and tasks. So things like tying our shoes, riding a bike, those things that kind of are in our muscle memory, if you will. And typically, we wouldn't expect to see any impairments in implicit memory in Parkinson's, but we certainly can see difficulties, declines in that explicit or declarative memory. We can also, so when we talk about explicit memory, we can break that further down into verbal and visual or visual spatial memory. And in Parkinson's disease, we can see difficulties with both verbal and visual memory, okay? Now, in mild Parkinson's disease dementia, memory deficits are less severe than those that we typically see with Alzheimer's disease. Though as Parkinson's disease dementia progresses, the severity of impairment in memory can match that seen in Alzheimer's disease. When we think about the pattern of difficulty with memory that we can see in individuals with Parkinson's disease, what we usually see is that individuals have difficulty retrieving information. So that might look like, you're having a conversation with somebody who has memory difficulties because of Parkinson's. And in the moment, they seem to be tracking and understanding, and they might be able to repeat back a little bit. But then maybe a few hours later or a couple of days later, they have trouble recalling those details of that conversation by themselves. But when you give them hints, you say, remember we talked about this, little cues or prompts, that typically jogs their memory, and then they're able to retrieve more of that information. That's the pattern of memory difficulties that we usually see. Although again, as dementia progresses, individuals may benefit less and less from those reminder hints. So executive dysfunction is commonly seen in Parkinson's disease dementia. And we could also see executive weakness in mild cognitive impairment associated with Parkinson's, as we'll talk about. Since we don't learn about executive functions in school, I always like to use a sports example to help explain what these are. And I know that we're in Wisconsin, we're in Packer land here, so I like to use a football example. As we all know, Aaron Rodgers is the quarterback of the Packers. And so during games, he needs to use a lot of these executive functions like organization, planning, he's reasoning, he's strategizing, he's solving problems, he's thinking flexibly during the game. All of those different activities that he does in the game are examples of executive functions, these higher level thinking skills, okay? And they involve the frontal lobe and the frontal lobe's connections to different parts of the brain. And again, these skills are commonly compromised in individuals with Parkinson's disease, especially those individuals that have dementia. So as we've just been discussing, cognitive deficits are commonly seen in Parkinson's disease, okay? And now I'd like to talk about kind of the different levels of cognitive impairment that we can see in Parkinson's. And so I like to describe it as a continuum. And so over here at the beginning of the continuum is something called Parkinson's disease mild cognitive impairment, also known as MCI. Okay, and over here at the other end is Parkinson's disease dementia. And we're going to start out by talking about MCI, and then we're going to transition to talking about dementia. What we know is that approximately 27% of individuals with Parkinson's disease meet criteria for MCI, okay? This includes individuals who are just diagnosed with Parkinson's, okay? It can be seen at the time of diagnosis, and that could be affecting anywhere from about 35 to 43% of individuals at the time of diagnosis. MCI is a risk factor for progression into Parkinson's disease dementia, okay? MCI is associated with increasing age, disease duration, and disease severity. So when we think about the inclusion criteria for Parkinson's disease MCI, of course, the first one is a Parkinson's disease diagnosis. Then we also look for gradual decline in cognitive functioning over time. We're going to administer some formal measures that take a look at cognitive functioning. And when deficits arise, that would be consistent with MCI. We need to make sure that they're not significantly impacting somebody's functional independence. So things like our ability to manage our medications independently, or manage the finances, driving, working. Those functional skills are really key to assess when we're assessing for MCI, because really that functional ability and that intact functional status is what differentiates MCI from dementia. We also, of course, want to take a look at exclusion criteria when we're thinking about MCI. So if a patient meets criteria for dementia, they cannot also meet criteria for MCI. We want to think about other explanations for cognitive impairment. So things like stroke or other neurologic conditions that can lead to cognitive dysfunction. We want to think about mental health symptoms and their severity, and could they be explaining the cognitive difficulties that somebody is having? We also want to think about medications that are prescribed and whether or not they can be contributing. We want to also keep in mind that there are other Parkinson's disease associated comorbid conditions that can potentially influence how somebody does on testing with us. So things like motor symptoms, depression and anxiety, sleepiness, psychosis. And if these symptoms are significant enough that they interfere with neuropsychological testing, then they may also interfere with our ability to clearly identify an MCI diagnosis. So when we're thinking about identifying MCI, we can do an abbreviated assessment where maybe a neurologist is administering a cognitive screener. Or we can do a more comprehensive assessment where individuals come see somebody like me, a neuropsychologist, and we do a comprehensive assessment where we're taking a look at memory and thinking skills very broadly. And what we are looking for are any changes in memory and thinking skills that are more than we would expect with normal aging, and that represent a significant decline from where somebody's been functioning. And we measure that in a variety of ways. We're looking for impairment on at least 2 tests or in 2 areas, okay? And we would go over that during the feedback session, talking about areas of weakness that came up on testing and whether or not that's consistent with MCI that can be seen in Parkinson's disease. Now, when we think about MCI, there are different subtypes, okay? So there is the single domain subtype, which involves difficulties in an area that can be seen to be problematic in Parkinson's. So for example, executive functioning. Somebody can come in and they have problems just with executive functions, those higher level thinking skills. And so we could make a diagnosis of MCI as long as those weaknesses aren't impacting their everyday functions. This is in comparison to MCI multiple domain, where you see difficulties in multiple aspects of cognitive functioning, like for example, memory and attention, or memory and executive function. What research has shown is that the most common subtype is single domain non-amnestic, which means that there's impairment in any cognitive domain other than memory. All right, so predictors for MCI, predictors for Parkinson's disease dementia. So we know that MCI is a predictor for Parkinson's disease dementia. But what the research has found is that although it's a risk factor, it does not always progress into dementia for everyone. And that's why really early neuropsychological evaluation and then following over time is very important. And really recommended to help monitor cognition over time and guide intervention. When we look at the cognitive profile that is presenting the greatest risk for later development for dementia, what we see is that executive functioning limitations, visual spatial deficits, language weaknesses, and memory limitations are really the difficulties that are more commonly associated with progression to Parkinson's disease. And when we look at some studies that have occurred, a recent study that followed patients over 3 years found that individuals who had MCI at baseline had 39 times the risk of developing Parkinson's disease dementia compared to patients with normal cognition. So now let's transition to talking about Parkinson's disease dementia. And studies that have followed the same people over time have found that about 50% of those with Parkinson's disease develop dementia after 10 years. Those same studies have found that about 80% of individuals go on to develop dementia after having Parkinson's for about 20 years, okay? The mean age at Parkinson's disease diagnosis is approximately 71 years old. Identifying Parkinson's disease dementia is important because it impacts patients' functions and cares in many ways. So for example, many individuals with Parkinson's, especially in the beginning, are working. But as Parkinson's progresses and maybe individuals get diagnosed with MCI that progresses to dementia, we really need to think very critically about an individual's ability to work. Are they still able to perform their job duties safely and successfully? We need to think about things like excessive daytime sleepiness, in addition to cognitive impairment, and how that impacts somebody's ability to work. We also need to keep in mind that difficulties, declines in abilities such as reasoning, insight, and judgment are seen in individuals with Parkinson's disease dementia. And this impacts or can impact individuals' ability to manage their own medications and finances, their health care, and make important decisions about their life circumstances. So we want to be very mindful about assessing and monitoring those skills over time. And lastly, I know this is nobody's favorite topic to talk about, but cognitive difficulties that are seen in dementia can certainly affect driving skills. And so we want to make sure that we're talking about that early on in the disease process. Okay. So some risk factors for Parkinson's disease dementia. What we know is that age, specifically age 70 or older, is the greatest risk factor for developing dementia associated with Parkinson's disease, more so than age of onset of Parkinson's. And studies have found that people with early onset Parkinson's disease had significantly longer times before they develop cognitive impairment. Okay. Other risk factors include MCI at baseline, as we've discussed, severity of motor dysfunction. So as some of you may be aware, there are two broad clinical phenotypes that are recognized in Parkinson's. So there's a tremor dominant group and a postural instability and gait disorder group. And what research has found is that the latter group, the postural instability and gait disorder group, is associated with more rapid cognitive decline and dementia. And so that's something that we want to be very aware of regarding the specific phenotype that somebody has in helping us plan for the future and possible onset of dementia. As the slide details, other risk factors for dementia include depression, lower SES, different cerebrovascular risk factors, and levodopa-induced confusion. And that may also be predictive of dementia as Parkinson's disease progresses. So in terms of the diagnostic criteria for Parkinson's disease dementia, of course, Parkinson's disease has to be confirmed. With dementia, what we see is this kind of slow, subtle process of gradual cognitive decline over time. And on testing, we're going to see impairment in more than one cognitive domain. Of course, there's that decline from the previous level of functioning, and this is key, the functional impairment. So difficulties with work, driving, managing medications, and finances. It's important to note that the functional impairment cannot be attributable to motor symptoms or autonomic symptoms, but must reflect cognitive difficulties. Okay. So diagnostic criteria that are associated for Parkinson's disease dementia include cognitive features, which we've discussed, and also behavior features. So things like changes in mood, like anxiety, depression, personality, behavior, hallucinations, delusions, apathy, excessive daytime fatigue. And we're going to talk about these things in just a minute. So we also want to be mindful of considering factors that may make a Parkinson's disease dementia diagnosis uncertain or rule it out. One of the more important things that we want to assess is the timeline of symptom onset, specifically motor symptom onset and cognitive symptom onset. And you guys might be familiar with or have heard a condition called dementia with Lewy bodies. And with dementia with Lewy bodies, we can see the onset of cognitive and motor changes in about a year of each other. And so oftentimes when individuals are first presenting to neurology with changes in cognition and motor functions, dementia with Lewy bodies is raised as a possible diagnostic consideration. And so we need to make sure that that's being considered and potentially ruled out when we're thinking about Parkinson's disease and Parkinson's disease dementia. We also want to assess and rule out anything else that could potentially be contributing or causing cognitive impairment, like stroke, brain injury, delirium, which is just a fancy way of saying confusion that can be, for example, commonly seen in older adults that have a urinary tract infection. All right, so what are the things that we can do to manage cognitive changes seen in Parkinson's disease? One of the first recommendations that we usually make is to get a thorough medical and psychiatric workup just to make sure that nothing else isn't contributing to the symptoms that somebody is experiencing. Medication review is very important because some of the medications that can be prescribed for Parkinson's disease, for example, anticholinergic medications or dopamine agonists, they can negatively impact cognition, personality, behavior, and so we really want to make sure that that medication review is done with neurology and done early on in the disease process. There are medications that can be prescribed for individuals with Parkinson's disease dementia, specifically cholinesterase inhibitors such as donepezil, which is also known as Aricept, and Exelon have been found to improve cognitive functioning as well as behavior disturbance that we can see in Parkinson's disease dementia. And these medications are commonly prescribed in Parkinson's disease dementia. And so if that's something that has not been discussed with neurology, I would always encourage you to start there and ask your neurologist about, possible treatment options for dementia. In terms of managing cognitive changes, we could also recommend cognitive rehab. This will really depend on how severe the cognitive impairment is, but especially early on in the disease process, if there's MCI or even, early stage dementia, cognitive rehab can be really helpful. And I like to describe cognitive rehab as just physical therapy for your brain. So lots of times speech therapists do cognitive rehab and they'll teach individuals tips and tricks and strategies, workarounds for managing the cognitive changes that we can see in Parkinson's disease, MCI, and dementia. Future planning is something that I always encourage my patients and their family members, caregivers to think about earlier on in the disease process. So things like work, driving, power of attorney for healthcare and finances, future healthcare preferences, just involving, individuals with Parkinson's disease in those conversations and those plans as early as possible so that we really understand what they would prefer and can honor those choices later on, maybe as they're not able to be as participatory in those conversations as they were at the beginning of the disease process. Something else that we always want to encourage is just family support and caregiving resources for managing cognitive changes. All right, so we're going to wrap up by talking about some of the cognitive and behavioral changes that we can see in Parkinson's disease. And during the course of the disease, many patients experience neuropsychiatric difficulties like depression, anxiety, sleep disturbance, psychosis, behavioral changes. And what the research has shown us and what we know just by working with these individuals is that for patients and families, these changes are often more problematic and more distressing than the motor changes that we can see with Parkinson's disease. So mood disturbance, frequently affective disorders, so things like anxiety and depression, predate the onset of motor symptoms about 4 to 6 years before a diagnosis of Parkinson's is made. Depression is one of the most frequently reported neuropsychiatric disturbances in Parkinson's, seen in about 40 to 50% of individuals with the condition. It can develop at any point in time over the course of Parkinson's, but also can be seen at the onset. There are similar rates for anxiety in Parkinson's. We can also see manic and hypomanic symptoms in Parkinson's. They're not well characterized, but they can include symptoms like elevated mood, irritability, hyperactivity, increased goal-directed activity, including risky behaviors. And in Parkinson's, isolated manic or hypomanic symptoms most often occur as the result of dopaminergic medications or neurosurgical treatments. So when we think of dopaminergic medications, some common ones are things like Mirapex and Requip. And some patients might show signs of hypomania in the on state, okay, when medications are working, with increased irritability and goal-directed activities, okay? Patients who have levodopa motor-related fluctuations tend to be more anxious than those without fluctuations. And in some cases, we can see severe anxiety or panic attacks during off periods. As we talked about, depression is commonly seen in individuals with Parkinson's. I have listed here just some common symptoms of depression that you guys can read through, but basically persistent, pervasive low mood. Individuals are not able to get the same enjoyment out of things, activities that they used to. They may have stopped doing previously enjoyed activities. It's important to note that patients who don't have depression, but have Parkinson's disease, they may limit their usual hobbies or activities, for example, like woodworking, activities that involve fine motor skills because of motor symptoms. But a depressed patient with Parkinson's disease will fail to seek alternative activities to enjoy. And that can really help us differentiate between depression and not depression in individuals with Parkinson's. You can also see things like pessimism, negative thinking, feeling hopeless or helpless, guilt, tearfulness, and less frequently, though still there, suicidal ideation. Hallucinations and delusions. So hallucinations are common in Parkinson's with rates as high as 65% in individuals who have dementia associated with Parkinson's disease. Hallucinations in non-demented individuals with Parkinson's, they're a strong predictor of the later development of dementia. Visual hallucinations are approximately twice as common as auditory hallucinations. The majority of these visual hallucinations are complex, they're well-formed, they're of anonymous people, but they could also be family members, body parts, animals, machines. They tend to be in color and again, very well-formed. Delusions or false beliefs are less common, though research has found rates around 17% overall in patients with Parkinson's disease and about 25 to 30% of patients with Parkinson's disease dementia experience delusions, although delusions and hallucinations can co-occur. Now, when we think about delusions, we typically are thinking about paranoid delusions and something called the phantom border delusion. And the phantom border delusion is a belief that uninvited people are living in the individual's home, or people are coming and going. And that is one of the more common delusions that we can see in Parkinson's disease dementia. And I'd just like to point out that hallucinations and delusions are very distressing for patients and caregivers. These can occur with the disease progression as well as a medication side effect. So if you or a loved one are experiencing any of these symptoms, please don't hesitate to reach out and let your providers know. Apathy includes symptoms of reduced interest, loss of motivation, also commonly seen in individuals with Parkinson's disease dementia. And finally, impulse control disorders can be seen in Parkinson's disease. They occur in approximately 14% of individuals with Parkinson's, and they may include behaviors such as excessive gambling, compulsive shopping or eating, hypersexuality, overuse of dopaminergic medications, hoarding, impulsive smoking. And so again, sometimes it can be hard to talk about these behavioral changes with providers. I would encourage you guys to do so in the spirit of disclosing everything so that your providers can get a good understanding of what's going on to properly guide treatment. All right, so lastly, just a couple of tips on managing psychological changes. Antidepressants, so there are a variety of antidepressants that can be used with success to treat depression in individuals with Parkinson's disease. Psychotherapy can also be quite helpful for teaching adaptive strategies for managing, anxiety, depression, other mood-related changes, in addition to coping with the functional and cognitive changes that are commonly seen in Parkinson's. We all know exercise is good for all of us. It's also a great way to manage changes in mood and cognition in Parkinson's. And I know that, WPA sponsors a lot of great exercise groups. And a lot of my patients are involved in these groups. And so I would really encourage you to talk to your providers about what exercise might be medically approved for you or your loved one. Sleep hygiene is something that we also want to pay attention to. We know that in general, good sleep is very important for optimal brain functioning. And if we're not getting good quality restorative sleep, that can be contributing to cognitive impairment and also changes in our mood. Medications can help with some of the sleep changes that we see in Parkinson's. Things like again, excessive daytime sleepiness and other symptoms. So talk to your provider about possible treatment there. Also, peer support groups can be really helpful, as well as caregiver support groups. And I do have some resources for everyone on this page. We're all familiar with WPA and the American Parkinson Disease Association, but there are also some other links here that could be helpful. And I'm happy to take questions. And thank you guys very much. It was a pleasure giving this presentation today.
Dr. Rothong, thank you so much. For those who don't know me, I'm Jeremy Oddie, the Director of Outreach and Education with Wisconsin Parkinson Association. I'll remind you all that at the bottom of your screen, there's a tab that says Q&A. If you have any questions, please type those in and we will ask those of Dr. Rothong. A couple questions that have come up that I hear constantly with this topic, but things that people have also asked. How do I know if it's cognitive changes versus normal aging?
Sure, I get that question a lot too, Jeremy, and it's a good one. So we know that as we all age, there are normal cognitive changes that we would expect to see. Now, in individuals with Parkinson's disease, we could also see normal age-related cognitive changes, okay? But we could see changes specifically associated with Parkinson's disease. And that's where a neuropsychological evaluation can be very helpful. So coming in to see somebody like me or me, where we can take an individual through a thorough assessment and see if weaknesses are showing up on testing, if they are associated with those that we would see with normal aging, okay? So things like, maybe just a little bit of forgetfulness or just mild difficulties paying attention or concentrating over time. Or if what we're seeing is more than what we would expect with normal aging, more consistent with that pattern of deficits that we would see with Parkinson's disease, either MCI if there's no functional impairment, or with Parkinson's disease dementia if there is functional impairment. So I'd say overall, if you're at all concerned, talk to your provider and ask them to place a consult for a neuropsychological evaluation. And that way we could certainly get that baseline and help to see if what you're experiencing falls within the realm of normal age-related cognitive change or is a bit more and is consistent with what we could see with Parkinson's.
Okay. One of the questions just popped up and you kind of just touched on, you said, to see a neuropsychologist like yourself, get a referral from your Parkinson's doctor. Somebody's asking, can I contact you directly and set up an appointment, or does that have to come through my provider?
Sure. So usually the referrals come in from a provider. It doesn't necessarily have to be an Advocate Aurora provider. Most commonly, I see Advocate Aurora patients just because I'm employed by Advocate Aurora. But I do also take outside referrals. And so usually there's, a neurologist or a primary care doctor who is making that referral. And that way we have somebody who's coordinating care. And we're in touch. I very commonly, consult with the referring provider or the care team. And I'm happy to see any and all of you, though not at all at once, but I'm very happy to do that or consult with you. I'm happy to share my contact information, maybe through Jeremy or Carolyn, and really help as well as I can.
Excellent, thank you. Jan just asked a question, does some anxiety or depression acquired due to being concerned about the progression of Parkinson's disease? So are people more anxious and depressed because Parkinson's is so unknown that they're just worried about the progression?
Yes, absolutely. I do see this with my patients as well, where there's maybe no significant mental health history. There's no history of anxiety or depression, nothing that even predated the onset of motor symptoms. But after diagnosis, maybe even after some time has passed and individuals have more time to kind of process the diagnosis and for that to sink in, anxiety and depression can certainly start to appear. And for some of my patients, I really see that anxiety plays a significant role because of exactly what you just mentioned, Jeremy. There is a lot of uncertainty unknown about individual disease progression and exactly what that's going to look like for somebody. And so, in the patients that I work with, we talk about changes in mood like anxiety and depression, in relation to a Parkinson's disease diagnosis, in relation to changes in functioning associated with the condition. And we assess for that during the evaluation. And we also talk about different strategies, interventions that we can recommend early on so that we can not only recognize those symptoms, but help individuals better manage and cope with them so that they don't become so significant where they're really impacting somebody's functioning.
It kind of maybe a follow-up to that, and maybe an obvious question, but one I do see a lot. If the person had a lot of anxiety or other issues before Parkinson's disease, being diagnosed with a chronic condition aren't going to make those things magically better, right? They may actually make them worse.
Absolutely. We can see exacerbation of underlying, long-standing anxiety, depression. I've certainly worked with individuals where that is the case. And even in some of those folks, a lot of them, maybe have never established formal mental health care, or maybe we're hesitant to do so for a number of reasons. And that's okay. There's no judgment. What I just like to say is that I'm a consultant and I offer patients lots of resources. So we'll talk about things like that during an evaluation, and we'll normalize exacerbation of maybe long-standing anxiety and depression upon Parkinson's disease diagnosis. And then we'll, more importantly, talk about things to do to treat it so that somebody doesn't have to be suffering with those symptoms. There are a lot of good treatments out there. And if folks are hesitant to explore like medication options for mood or behavior changes, and again, I'm not a psychiatrist, I'm a psychologist by training, so I don't prescribe medications and I don't push medications either. It's really an individual's choice. But I always tell people we don't need to necessarily look at medications to manage those symptoms. We certainly can, and sometimes it's indicated and it can be quite helpful. But good old-fashioned psychotherapy has come a long way and can really offer a lot of positive strategies, tips, tools, even just somebody who is not a member of your family to talk to and process, the Parkinson's diagnosis with can be really, really useful. And so I try to take a really supportive therapeutic approach when we talk about these mood changes and different treatment options. No one treatment plan fits everybody. I really do believe in an individually tailored approach. And I'm sure a lot of your providers also have that same way of working and treating folks. And so those are just some things that I would think about.
I appreciate that. I think it's really important, like you said, just to talk about it. I oftentimes at support groups, I share a personal story where I have a friend who's, when she was his mom was diagnosed with Parkinson's disease, and when she met with a psychotherapist or a neuropsychologist, they asked her, well, how long have you been battling depression? And it had been since her husband had died 18 years ago. And her mood got better, her symptoms got better. There was no medication change. It was just finally somebody acknowledged it and she could talk about it. So I think you hit on all those points.
Absolutely.
So one more, two questions, but one real quick one. Arthur asked, and I don't know if you're the best person to ask, but I'll put this out there. Do you know how often aspiration with food occurs with people with Parkinson's disease who maybe have speech issues?
Sure. So I would say, just a friendly reminder, I'm not an MD, not a neurologist. So I would say that question is probably better geared to one of those providers. It's a good question. We do have folks who have difficulties with aspiration, but I don't want to speak outside of my area of expertise.
And I can probably refer Arthur to, if you go to our website, Gary mentioned at wiparkinson.org. We do have a couple of videos with speech therapists who talk about aspiration and things you can do. So definitely check that out. The last question I'm going to ask you kind of touched on it at the end, caregivers. You know, we talk so much about the patients and all they're going through and the person with Parkinson's disease. From your role, what are things you would recommend a caregiver can do to help deal with maybe some of the depression and changes they're dealing with and anxiety that they're dealing with, or with the major life changes that has happened?
Absolutely. So I work a lot with patients and their families, caregivers, and once we really get to know folks, right, I think they feel more comfortable kind of disclosing that there is some caregiver stress, whether that be anxiety, depression, difficulties coping with their loved ones, functional changes or cognitive impairments or behavioral changes. And so we do end up talking about those symptoms in caregivers and normalizing those symptoms. It's okay to feel burnt out. It's probably expected over, some time. It's okay to acknowledge anxiety, depression. It's okay to acknowledge grief over, a change in your loved one's functioning. And I would really encourage those caregivers to, if they can, find support, whether that be family, friends, support through WPA and other community organizations, national organizations. Now kind of this virtual awakening, if you will, has opened up a variety of additional avenues for online support. And I think that's amazing. And it really does open up that access. And so I think the first step is just acknowledging that it's okay as a caregiver to feel stressed, to feel like you're uncertain about what's going on and how to help, to have anxiety and depression. And we're all here to help. We can point you in the right direction. Sometimes it can be as simple as referring you to a caregiving support group, whether that be in person safely or virtually. And sometimes it's maybe making a gentle recommendation to think about some counseling for yourself. Again, it's not one size fits all. I like to really talk with caregivers and kind of see what's going on and see how we can help. But there are a variety of different supports out there, and we're all here to help guide you.
Thank you very much. I think that's a great wrap up. Really emphasizes the need to care for both the care partner and the person with Parkinson's disease. Thank you so much for your time, Dr. Rothong. Now I'm going to hand it over to Gary Garland, who's going to wrap up and have a few closing comments.
Thank you.
Yeah, big thank you, Dr. Rothong, for your help today, taking a challenging subject, but one that's on the mind for many in the Parkinson community and making it understandable and offering solutions. So thank you once again. And tomorrow, we think folks have been, all of us have been sitting around a little too much. So we're going to get you moving a little bit. It's the topic's going to be activity and exercise. And we all know how good exercise is for all of us, and it's especially crucial for those with Parkinson's. And it ties in a little bit, I think, to Dr. Rothong's conversation today. Exercise can have some really positive mental health benefits. We're going to have Patrick Barron, who's a physical therapist and owner of Fastback Physical Therapy in New Berlin. And he's going to be pairing up with our excellent exercise coordinator, Mary Wood. Some of you know her through virtual exercise we've been doing for the last year. And they're going to discuss the importance of intense exercise and lead us through some sample workouts. So it's gonna be a lot of fun. So join us tomorrow. When you do that, the link you use today is the same link that you'll use tomorrow. If you want any friends to join us, but they're not signed up, have them go to our website and register first. It's wiparkinson.org. As we mentioned earlier, the programs are online. The recordings of the first 3 days are online now. You can check those out as well. And in closing, I just want to thank our sponsors again, Medtronic, Amneal, Boston Scientific, and Kyowa Kirin. Tomorrow afternoon, you're going to receive an email with a link for a program evaluation. I've spoken before about how important it is for us to get your feedback, how these programs have worked for you. You're also going to get some information from those great sponsors as they help us make these programs possible. I'm wishing you the best for the rest of your afternoon and hope to see you tomorrow. Have a great day.